All right, good afternoon and welcome everyone. My name is Fawn Busbaum. I'm the Strategic Partnership Coordinator here at ACHA. As we continue into unmute of your campus stakeholders, and we're hoping that today's Q&A session will help. So here's how to have an opportunity to update you on the very latest information available. At any time, feel free to type a question into the chat box. When our speakers are done giving answers to our speakers, we give them the opportunity to answer. Chances are we won't be able to get to everyone's questions today, but we are keeping track of all of them and we'll try to address them in a frequently asked one. If you have any other questions or concerns, I've posted my email in the chat box and it'll be on the last slide as well. And I will make sure your question that we will be recording today's session and uploading this to the ACHA COVID-19 webpage. So if you have a colleague who couldn't make it today, please pass along that information. Also, I have brought everyone in on mute, but just you might want to check and make sure that you're still, that will help things along. With that said, let's get going. I'm pleased to introduce our two very distinguished speakers, both of whom currently serve on the ACHA COVID-19 Task President and Executive Director of Emory University Student Health Services. He currently serves as an Associate Professor of Family and Preventive Medicine at the Emory University School of Medicine and is also a past president of the ACHA Lifetime Achievement Award. Craig Roberts is an Epidemiologist Emeritus from the University of Wisconsin-Madison and when not consumed with COVID task data project team on the Foundation's Vaccine Survey Project and on ACHA's Vaccine Preventable Disease Advisory Committee. I'll now turn it over to the two of you.
Well, welcome everyone. I hope that my audio is a little better perhaps than Robin's.
Oh, sorry.
So I think Robin, it is your headset microphone that is the problem there, because I'm all of a sudden seeing everyone can hear me just fine. Right. Great. Well, thanks for joining us today. We're going to run through a few things pretty quickly because, as Robin mentioned, we received over 200 questions and we're not going to get to all of them. But Mike and I would like to just highlight a few things that happened this week, some important updates to know about, and then we'll just open it up to the pre-selected questions, and Robin's going to read those. So could I have the next slide, please? Which I think is, I am in control. All right, so COVID, just a quick update. Every time I check back at the Johns Hopkins site, I'm getting a different number. So this is changing by the hour. So I just rounded them off to the nearest 1,000. But I think by the end of the day today, we'll see that we've had 250,000 cases worldwide. In the U.S. now, over 14,000, probably be 15,000 by the end of today, with 200 deaths. None of that is surprising to you if you've been following the news. We now have cases in all 50 states and at least 4 different territories. And the important thing for this week that's really changed is we now have community transmission established in all 50 states and really in most areas of those states. So from a perspective of how do we quarantine and isolate, and which we'll be talking about in a little bit, essentially any travel in the United States is now a risk. Yesterday, the State Department declared a level 4 advisory, which means that they are telling American citizens they should not travel anywhere outside the country. CDC has also last week issued a global level 2 advisory. Global alerts and advisories mean the entire world is under the same advisory. It's no longer country by country. And a level 2 is usual precautions, but it does mean that for the entire United States, travel from one state to another is basically the same as going to another country, except for the highest risk countries like China and Europe. The other major thing that happened this week in terms of news was CDC reported that a sizable proportion of hospitalizations in the US so far, and they're looking at, if I remember the numbers right, about 2,500 cases. 20% of those cases occurred in young adults. This obviously has some very important implications for our population in particular, and a sense of young adults perhaps not, and college students not so concerned about their risk. This really changes that situation, and I think that's an important message to get across to young adults. Next slide. So some additional trending topics, we'll just touch on these. Some of these are very recent, but these seem to be the hot topics that people are really talking about and asking questions about. And I'll tell you in advance that we actually don't have firm answers for any of these. These are all evolving situations. This is a novel virus, and our response is novel, and our knowledge in particular about the virus is really very new. The good news is that there's never been a scientific effort like this applied in the past at such a great rate. There have been over 1,200 studies published to date about coronavirus. CDC itself on its website has some 450 separate documents available. So But the main things you're probably hearing about this week are what is the question about persistence of virus in aerosols and on surfaces generated from a letter that was published in the New England Journal. And we can talk about that more in the Q&A. Yesterday's news, what about using chloroquine or hydroxychloroquine or similar medications for treatment or for prophylaxis? That was based on a very small study done in China. And has some promising results, but in terms of quality of data at this point, it's very, very preliminary. So I would caution people mostly not to get too excited about that yet. We'll see where that goes. There is at least one clinical trial in progress at the University of Minnesota. What about the role of asymptomatic infection versus asymptomatic shedding, and how does that contribute to transmission overall? This is largely a data-free zone. We certainly think some asymptomatic transmission is happening. We know people are shedding virus asymptomatically to some degree. That is primarily in the 24 to 48 hours before the onset of recognized symptoms, or what we'd call in the pre-symptomatic period. People are probably not shedding virus from the moment they become infected. Just like any other bacterial or viral disease, it does take a while for virus to replicate and for people to start shedding. And then what about other clinical, other vaccines? The clinical trial was started this week for one candidate vaccine at the University of Washington. That is a record time to initiate a clinical trial. So it still is likely to take a year before we have results and that's actually available to the marketplace. And finally, the other big hot question this week was, what about nonsteroidal drugs for treatment, yay or nay? An area of great controversy. Many people thinking the use of NSAIDs is a problem, and other people saying it's really not a problem. So stay tuned for that. Again, I think Mike might want to comment in a bit, but at this point, we don't have an answer for that either, whether you should or should not. And I would just caution you to not make a formal recommendation yet until that issue is resolved. All right, I did want to talk a little bit about quarantine and isolation. It's important to understand that these are different terms, particularly in public health speak. They are not interchangeable. So quarantine refers specifically to the restriction of movement or isolation of people who are in an exposed state. So they are well, they are not symptomatic, they have been exposed, but do not have a diagnosis. That's quarantine. We rarely use quarantine for infectious diseases in this country. Isolation, by contrast, isolation refers to the restriction of movement of people who are suspected to be infected or have been documented to be infected and have an illness. And isolation is used for many, many, many diseases, measles, for mumps, pertussis, on and on. So isolation is very familiar to most of you. We talk a lot about self-quarantine, and some of the questions were, what exactly is self-quarantine? Well, that just means it's a voluntary process. We ask people to stay at home and follow some guidance about their quarantine. And again, that's for people who are exposed and well, but not yet diagnosed. A type of essentially what people are thinking of quarantine now is what's really referred to as self-observation. That means you are monitoring for symptoms, signs and symptoms, or perhaps taking your temperature, but you are not formally in a quarantine sort of status. No one has asked you, you haven't been specifically exposed, but you may have some increased risk. And really this applies to the entire United States population at this point. Everybody should be aware of signs and symptoms and what to do if they start to develop them. And then the third aspect, again, is what is self-isolation? Again, isolation is for people who are infected, people who have a positive test, people who have typical symptoms and meet a clinical case definition. For most all of these, 14 days is the standard period that people need to be in those states. Isolation is sometimes now a shorter period, and I'll talk about that on the next slide. It's also important to recognize that though there are guidelines for quarantine and isolation on CDC's website, that is only advice from CDC. The actual rules and regulations and instructions about quarantine and isolation are actually at the discretion of your local or state health department, particularly for a legal quarantine order, which is not being used very much. But understand that even if the CDC says one thing, if your local health department tells you another thing, that local health department has the upper hand. They're the ones who are in charge of when people can be released from quarantine or isolation. And for that reason, it's very important for colleges and universities to have a close working relationship with their health department. So the news this week, the guidance for when someone can be released from isolation was changed, updated by CDC. Prior to Tuesday, the guidance had been in place since early February and reflected that people needed to have a series of negative PCR tests before they could be released from isolation. That serial testing obviously was a lot of work and a lot of risk for healthcare providers. And in a period of time when testing was not widely available, it was also consuming a lot of testing resources. So CDC has now added the option that you do not need to be tested to be let out of isolation, but following the criteria in the bottom of the slide, that is, there should be at least 3 days have passed since recovery from symptoms, which was defined specifically as the resolution of fever and improvement in respiratory symptoms. So fever that drops to 98 or 99 and cough is no longer productive. And then in addition, at least 7 days have passed since symptoms first appeared. So rather than 14 days, it actually is 7 since the exposure or the onset of symptoms. So I'm going to stop there, and Mike is going to talk about PPE issues, and then he has a couple slides, and then we'll do questions. Mike?
Thank you, Craig. Well, first of all, let me say that if you're asked to do an ACHA webinar, please say yes if Craig Roberts can be your co-presenter. Otherwise, I'm not so sure. Also, just to briefly give a plug for the ACHA guidelines, which were published on March 3rd, published by the task force, of which Craig and I are both members. And it's about preparing for COVID-19 on your campus. Most of the material that's in there is still valid. As you know, things are changing so rapidly, and we hope that it will give you at least some good advice in the early stages of our responses on our campuses. There have been some recent changes in recommendations regarding PPE, and these are important for us because we are in a period of limited availability of N95 respirators, and that may be something that is affecting you on your campus. And so the first is the current guidance by CDC on minimum PPE requirements if you're caring for a suspected or confirmed COVID-19 patient, and you don't have unlimited access or at least access to an N95 respirator supply. And that would be isolation gown and gloves, surgical or procedure mask, and eye protection, with the rationale being that the main mode of transmission for COVID-19 is through droplets. Second is, when would you use and reuse N95 respirators? Those at this point, at a time of limited supply, are being reserved for procedures that might generate aerosol. So that would include some things that we don't do, which would be things such as intubation, but may also include some things that you are doing or may soon be doing in your college health service, which would be obtaining specimens for laboratory testing, either through a nasopharyngeal or oropharyngeal swab. And again, the rationale for that is that aerosol generating procedures can make the virus theoretically become briefly airborne. And therefore, that would be a situation under which an N95 would be recommended. Next slide, Craig. There we go. So what is this business about extended use and limited reuse of N95s? And this is based on the NIOSH recommendations. These are not new, but since most of us aren't using N95s on a day in, day out basis on our campus, it's a good thing just to quickly go over these before we go into the questions. Extended use of an N95 is the practice where you wear that same N95 respirator for repeated close contact encounters with several patients, but you do not remove the respirator. There are recommendations of how to protect that respirator, including potentially placing another mask over the surface of the respirator, a surgical mask, for example. that might give it some protection from splash. What is reuse? Reuse is where you use the same N95 respirator for multiple encounters, but you doff it after each encounter, and then you store it in between. And there are recommendations that would be worth looking at if you're going to do a reuse approach, where you, for example, you put the respirator in an open plastic bag or in an open paper bag, you hang it up in a separate room so that there is some airflow to help the mask appropriately dry. And limited reuse, which is what you see recommended, is where you have a fixed number of uses or a fixed amount of time that you're using that respirator. 8 hours of use is something that you commonly hear talked about by our infectious disease colleagues. Generally speaking, extended use is preferred because it involves less handling of the respirator. So that might be the opposite of what you would think just by thinking about the situation. The recommendation is that if you're going to be using your respirator for more than one person, consider using it for an extended period of time without doffing. Craig, let's go to the next slide. There are links on all these slides, by the way, that will link you to some of the CDC websites. Finally, there have been changes, as you know, about who should be tested. These are another set of recommendations that almost would be considered ancient history now. They're all of 11 days old since the CDC published these in the interim guidance. And so what are the current recommended COVID-19 testing groups? And it is a wider group, with the proviso being that these clinical criteria are evolving and they're subject to change. The first is hospitalized patients with signs or symptoms of COVID-19. Other symptomatic individuals who are at higher risk for poor outcomes. And you know this list, including older adults, which includes me, an individual with chronic medical conditions or immunocompromised states. Any person, including healthcare personnel, who's within 14 days of the onset of their symptoms and had close contact either with a laboratory confirmed COVID-19 patient or a person who is suspect for the disease, a PUI. The language which is in there from 11 days ago is about have a history of travel to affected geographic areas, which essentially is a moot point now, where the entire United States, for example, are now defined as level 2. There are epidemiologic factors which may be present in your specific jurisdiction where you are at what would possibly be called a, quote, hotspot, end quote, and that may contribute to your testing decisions, but clinicians make sure that you're thinking about other causes, testing for influenza, testing for respiratory syncytial virus, doing a respiratory virus panel, if that's something that's available to you at your lab. And finally, healthcare personnel. If a healthcare person has exposure to a PUI, as you're awaiting laboratory confirmation, if that healthcare personnel develops mild signs and symptoms, then serious consideration should be given, and maybe just take off the word consideration and test that healthcare provider. So now we'll go to our next slide, which is questions, and hopefully we'll have some answers for you. We have received a lot of questions online, and we know that there are questions coming in from the chat. So I'm going to turn it back over to Robin at this point, and she'll.
Okay. Thanks, Mike. Thanks, Craig. Can everyone hear me now?
Yes.
Does that sound better?
Much better.
I'm so sorry about that. We did get quite a few questions. I tried to organize them because a lot of them were sort of centered around some key topics. Mike, I'm going to start with you. Some of these are possibly rumors or just information that has not been verified, but a lot of people are asking, can you get coronavirus twice?
Well, it's unclear. And the SARS-CoV-2 is a novel virus, as Craig talked about, and as we all know. So we don't have an actual answer to that question. There have been some case reports, a very limited number of case reports of people who, quote, had a second infection, end quote, in China, and I believe at least one case has been talked about in the media in Japan. It's important to remember that being immune is not an all or nothing phenomenon. There are host factors involved in whether you're immune. You can have a partial immunity. And so all of these things could lead at least to the appearance of a person having a second infection, when in fact it may be a reemergence of the primary infection in someone who has underlying host factors or immunosuppression, for example. So it is felt right now, and again, this knowledge is evolving, that it's likely that the vast majority of people who are infected with this virus and recover will have extended immunity, hopefully for years, maybe for lifetime, but the jury's still out.
Okay, thank you. I'm not sure who wants to take this one. How long can the virus live on a surface? And then somewhat related to that, there's some questions about handling deliveries, boxes, takeout food, those kinds of questions.
So
The epidemiologist.
So I wanted to just briefly talk about that primary study that resulted in a lot of media attention this week. You should go and read the actual letter in the New England Journal if you haven't done so, and understand how that was done and the specifics behind it. So this was an experimental setting. It was done in a laboratory where they plated virus on those surfaces and then came back and measured them. And what I can mostly tell you is this is not unusual. Most all respiratory viruses can be recovered, or their genetic material can be recovered off of surfaces for some time. That doesn't always mean they're capable of causing new infections. And the important data that was in that, and the reason why I think you should go look at it is because there are some very nice graphs showing the drop-off over time of the quantity of virus. So they started, for example, with the surface with, I believe, around 10,000 virus particles per mil. And after the 72 hours, it was actually down to less than 10 viral particles per mil. So there seems to be a rapid exponential log type drop in the quantity of virus that was present, and that's true with the aerosols as well. The aerosols study was done by generating aerosols in an enclosed drum, so it's not exactly like real life in the grocery store or the coffee shop, someone in front of you in line. So we really don't know what all that means. Are these surfaces contributing to transmission? I'm sure they are. To what degree? Do they account for 1% of transmission events or 50% of transmission events? We really have no idea about that. So the most intelligent course, I think, at this point is to assume that most surfaces that are touch, especially high touch surfaces like railings and counters and elevator buttons, are the riskiest. And we've said that for years with other things, including influenza and norovirus. And that's why hand washing is so important. It's why regular decontamination and cleaning of those surfaces in public spaces is important. As to cleaning groceries and so on, I think that probably is a bit of overkill, although I've heard people recommend it. But at this point, there's no data either way to sort of support whether you should wipe down everything you bring in the house. I know some people are doing that. I'll tell you that I am not.
Thank you. Okay, we have quite a few questions related to how contagious people are once their illness starts. When can they be released from quarantine? Is it based on symptoms? When is it safe for them to leave self-isolation, return to, I'm not sure they're returning to campus, but sort of leave their isolation. If you could speak to that.
So again, just to review, the terms quarantine and isolation mean different things. So it's important to understand when someone says they're in quarantine, what that means. Quarantine is for 14 days, and that's because quarantine needs to restrict people while they're in that potential incubation period, which can be up to 14 days. And quarantine doesn't really end early. If you've been exposed to the virus and you're formally told to go into self-quarantine, it's going to be for 14 days. Isolation, by contrast, is for people who are presumed to be infected or are documented to be infected or have symptoms and meet some sort of a clinical case definition. That would be typically the 7 days minimum, plus the 72 hours after the resolution of their primary symptoms. There is one additional slide I'm going to try and show you here.
Craig, do you want me to get there?
Yeah, you may have taken back control.
Didn't mean to, but okay, is this the one or next?
So yeah, this is the one. So a great graphic from virologist Ian McKay in Australia. This is a nice thing explaining how most viral and bacterial infections work, but recognize we have in the white arrow, the incubation period, and then the symptomatic period. People do become infectious sometime before they have the onset of symptoms, and this happens with almost all infectious diseases. The question is, how long is that period of time, and how infectious are people in that period of time? What's referred to as the pre-symptomatic phase or the pre-symptomatic infectious period. The best estimates for COVID seem to be that it's about 24 to 48 hours. And certainly in the 12 to 24 hours before people report the onset of a symptom, they are shedding lots of virus. But it does take a few days between the moment of infection and the time that you start producing virus, where it can actually be detected or would be infectious to another person. And that's going to vary a lot from person to person. It's not an automatic uniform thing. So the incubation period varies from roughly 2 days to 14 days, but we know that the median incubation period is about 5 days. And then it's actually a pretty tight interval around that. So in nearly everybody, about 98% of people have the onset of symptoms within 12 days. So I know there's a lot of concern about asymptomatic infection, but if you test people on day 2, they are almost certainly going to be negative on that test. If you test them on day 5 and in the morning and they have symptoms develop that afternoon, their test is probably going to be positive at that point. But again, you can't really rely on this specifically to guide you in terms of where somebody is, because there's a lot of individual variation.
Okay, thank you. Can you talk a little bit about the course of COVID-19 and how quick recovery comes?
I'll let Mike handle that.
Yeah, well, it varies. And as we know, this is an illness that can be mild. It can be asymptomatic. It can also lead to rapid respiratory failure and, unfortunately, death. And so the onset of illness, and again, Craig's got this slide up for you. Generally speaking, it is sometime within those first 4 to 7 days after exposure, with the outside edge being somewhere, I believe, Craig, you said day 12. And so
98% at day 12, yeah.
Yeah. And so the course can vary significantly.
Okay.
Craig, add on if helpful.
Yeah, do you?
Could you advance one more slide? I also have this graphic. This is from the Annals article, which was a close examination of the incubation period from cases in China. Just to show you that mean it's actually 5.1 days is where the median, excuse me, not the mean, the median 5.1 days, and then 98% percentile was at 12 days. But you can see, though, there is variation in the distribution of incubation period, and that's to the time of the first recognized symptom.
Okay, thank you. Are there antivirals that are used for influenza, HIV, or any of them, are they currently being studied to treat COVID-19?
Well, coronavirus is a different family and genus from those other viruses that that we have antivirals for. Craig talked earlier about hydroxychloroquine being looked at. So there are definitely people that are looking in the research labs and clinically at whether or not there are medications that may attenuate this illness or potentially even lead to a resolution of symptoms. But that work is ongoing. There really is no reason that if you saw someone that had been diagnosed with COVID-19 that you would put them on oseltamivir, on Tamiflu, for example. It's, again, a completely different family and genus of viruses. So I think we wait for the experts on this. There's no reason for us to be out there shotgunning with medications that have side effect profiles and sometimes quite significant and more significant in people that are at higher risk.
So we have quite a few questions regarding people coming back onto campus. So we have staff that may have been traveling. We have students that may be asked to come back onto campus to move out. Can you talk a little bit about that? I mean, some of these students have been down to Florida on spring break, or who knows where they've been. Are there suggestions, recommendations for taking temperatures, having them fill out questionnaires? Any thoughts on that?
Well, one thing is that travel anywhere in the United States is now considered to be a risk, the same as going to a level 2 country. So a student who's returning from Florida is basically in the same position as a student who might be returning from, say, Mexico or Peru or someplace like that, which is that they are suggested under the CDC guidance to follow self-observation. They would not usually be put into quarantine per se. So quarantine is recommended, again, formal quarantine, do not leave your house kind of quarantine for those level 3 countries, and which now includes most of Europe. But for traveling in the United States, they should be advised to watch for symptoms, and that would be the standard recommendation, subject to what your local health department may be telling you, because they may have a slightly different recommendation. But clearly, it depends what you mean by coming back on campus. So are they in your community? That is the guidance. What about residence halls? So the problem with congregate settings like a residence hall is it's very difficult to put somebody in isolation or even in quarantine. It just really complicates things. So schools are finding different approaches to that in many cases, or they're closing their residence halls completely and finding other housing for students or students returning home.
Okay.
And as Craig said, this is the perfect example of what self-observation is supposed to be about. And so doing twice a day temp checks and monitoring for the classic symptoms of COVID-19 is something that we would want to recommend to people that have been traveling and have not had a known exposure. And so making available to your students, for example, if you wanted to put together a self-observation sheet for monitoring, that's certainly what was done during 2015-16 during the Ebola outbreak for people that returned from West Africa, whether they were healthcare providers or they were people traveling, going home to West Africa, coming back to the United States. All of those people who did not have a known exposure and were asymptomatic were under self-observation, self-monitoring, and under some circumstances, depending upon the risk of the area they traveled to, they may have been in quarantine. But if we're talking about spring break, you're going to have a lot of students that should be paying attention to whether or not they have symptoms consistent with COVID-19.
Okay, I'm staying on that topic. Many schools have now shifted to online classes, but they are asking students to come back onto campus to move out of the residence halls. Do you recommend that there's some sort of screening as they walk in the door, temperature check, anything like that?
I'm going to say I've not seen any recommendations like that. Again, for asymptomatic people, that would usually not be necessary.
Okay.
I know that in some places and facilities, they are, of course, limiting the number of people who can go into the building, or they're having people schedule appointments, that sort of thing, and certainly maintaining that 6-foot distance in general. So just practicing good social distancing and good personal hygiene habits when you're in those joint spaces or public spaces. But there's no reason a student couldn't come back and retrieve their belongings. There's no reason to physically keep them away.
Okay.
And so just to add on to that, Robin, so many of the students who are returning may, if they were to actually be a case, could be in the that asymptomatic phase. There are people who have COVID-19 and are ultimately diagnosed who never ran fevers. And so it isn't like 100% of people who have the virus would be screened and appropriately identified by that method. So I would agree with what Craig's saying. It doesn't appear that it's something that's commonly being used in the college settings.
Thank you. For those who do still have students on campus, if a student begins to have symptoms and they would like to get testing, but they do not have transportation, do you have a recommendation on how to get that student to an urgent care center where they would do testing?
Well, this isn't a circumstance where we would want to call Uber. So I think that the thing that I would say is it makes a lot of sense right now to be thinking on your campus about the approach that you would take. And going to your public health department, which could be your local or territorial or tribal or state health department, and ask their advice, tell them what your situation is, and where you would be transporting or having students transported. I don't think that we want to find ourselves in a situation where we are using EMS to transport people who are going for testing. And if indeed what we expect will happen does happen and cases increase astronomically, then we can't afford to be using any of our transportation systems that are for healthcare, for moving patients exclusively to testing. So if you were to be in a situation where you made the decision on your campus and your health department supported that decision to use, for example, a university vehicle, it would be important for that student PUI to be in a mask, and for you, both whoever is the driver and the PUI, to be practicing appropriate hand washing and hand hygiene. And then I think if a vehicle is used, you would treat it like you would an exam room or an exam room where you're doing testing in your health center, and it should be appropriately cleaned according to protocols if there was a PUI in that space.
I would add a couple notes about testing. First of all, that testing can be done in any clinical setting. It is appropriate for routine primary care clinics to do COVID-19 testing if they are set up to do that. So any clinic that currently, for example, does influenza testing or respiratory virus testing usually should be able to do a COVID test. Once they figure out where to send the specimen, that is. So that our state health department has specifically asked primary care clinics to not transport people solely for the purpose of testing. It is not appropriate if you're seeing somebody in a primary care clinic to send them to the ER just to get tested, particularly if they have very mild symptoms, because that puts people in the ER at risk if that person is infected. If the person's not infected, they're probably being exposed to it when they get to the ER. And I would note that, at least in my state, only about 7% of the people tested come back positive. So that means 93% of the people who are being tested don't have COVID, and we should really not be, putting those people in harm's way either. So if you're a site that you don't have any experience collecting nasopharyngeal swabs, you don't usually do that kind of testing, then you need to find a place where it's done. And I would echo Mike's comment that your local or state health department is your best resource to find out where to get that to happen.
Okay, thank you.
I'm smiling because that's a much better answer. Maybe we can edit the tape, Robin.
I had meant to say at the outset, first of all, as a disclosure, that first of all, both Dr. Huey and I are retired from clinical practice. We are working from the comfort of our homes, couches and dining rooms through all of this, and we have a lot of respect and appreciation for those of you who are still working in student health centers on the front line, so thank you very much. On the other hand, Dr. Huey and I are both over the age of 60, and so we certainly have a personal interest in this as well. So,
yeah.
Well, that's actually a nice.
I'm going to quickly vamp on that, Robin, and say I hope that those of you who are over 60 or like me, over 65, don't use your concern about transmission of COVID-19 to not use handrails when you're going downstairs, even more important than going upstairs. So use the handrail and then appropriately clean your hands at the bottom.
This is a very bad time to break your hip.
Yeah,
yes,
very bad.
Well, it's a nice segue into quite a few questions around student health centers and employees. Should student health centers be closed? Should they shift to virtual triage? And then as far as staff go, should high-risk employees be forced to stop working?
I'll take the last part of it, and then maybe we'll tag team on the other ones, Craig. The issues about staff who are over age 60, and particularly staff who have underlying conditions that put them at increased risk, it's a very complicated, big question. And it's something that I think you're going to want to involve your general counsel in and your senior leadership and talk it through. I have a colleague who said to me earlier this week, if I removed everyone from my health center staff who was over age 60, we wouldn't have anybody working in the health center. So there are going to be a lot of us out there providing services. So I guess maybe a couple of examples I might use, and again, you're going to make this decision with the involvement of the people that help you deal with complex problems on your campus. But if you're big enough, you could consider whether or not you have roles that people who are in higher risk groups could play. Maybe perhaps that role is not in the direct triage of PUIs. Maybe it is not in the testing. Maybe it's in other areas of the health center. And then I think that as most of us do in leadership, we try to deal with these kind of questions on a case-by-case basis, and making your staff understand that you're open to individual discussion, that if they're willing to share with you concerns that they have about risk factors, also understanding that they have a right to privacy, and ensuring them that privacy. If you were to make a decision to remove a staff member from care, or you were going to move them to work in a different area, then it's important for us to say that that decision was made appropriately and otherwise protect the privacy of that person.
Yeah, it's a challenging question, and I think even the question of whether your health service will continue providing services is obviously going to depend on your staffing levels. In general, I think for many students, we are their healthcare, and it's important to remain of service to them, whether it's virtually or in person. So you have to figure out on your own campus with your colleagues and your administration how that's going to work and how that's going to play out.
Thank you. There are quite a few questions around the topic of telemedicine, telemental health. Mike, you want to take that one?
Yeah, we said that we weren't going to deal with telemental health today and telemedicine today because we want to give you a preview of next Friday's Q&A session at 3 p.m. on Friday, the 27th of March. Will be a session about telehealth and telemental health. But this is a huge series of questions, both in the written questions and in questions that we're receiving live right now, are about telehealth. And just to call your attention to one document, the document that was published in 2017 by HEMHA, which is the Higher Education Mental Health Alliance, of which ACHA is a member, and a whole host of other mental health organizations, including AUCCCD, the Counseling Center Organization, and NASPA, and the American College Counseling Association, and the APA, and the American Psychiatric Association. It's a whole group of people that participated in writing a document on telemental health, and it's called College Counseling from a Distance, Deciding Whether and When to Engage in Telemental Health Services. And so if you Google that, the entire document is available to you online. It's a great read, and maybe that's how you spend the week in preparation for next Friday's webinar, which will be about telehealth.
Thank you. Craig, did you want to add anything?
Nope.
Okay.
Other than, I mean, it's the use of telehealth is pretty novel in college health too. So it's another aspect of this virus that is, we're all learning how to do something that we probably have never done before.
Yeah. Take a look at the HHS publication from 2 days ago, which was about relaxing HIPAA restrictions when telehealth is used in good faith, and it's not a public forward-facing type of IT system like Facebook, for example. At least that's what I'm told. I don't do Facebook. And if you're going to get involved in telehealth, make sure that you're working with your general counsel and that you talk about concerns related to practice across state lines, which is not part of the HHS relaxing of HIPAA guidelines, a completely separate topic, and something that we shouldn't be ignoring.
Right.
Unless there's something new, Craig, in the last 2 days, because there could be. Everything's happening so fast.
No, we've been hearing from schools that people are using all kinds of different things. People are using Zoom, people are using Skype, people are using FaceTime. And I think probably to start with, if you're using, and there are also some of the EHRs, the ability to do telehealth is sometimes embedded in the EHR system itself, which is great. And there are specialty systems for telehealth. But if you're using something simple like this platform, Zoom or Skype, one of the best practices is simply to document that in the record and what you talk. It's just like having a phone call. If you're on call and you're talking to a student in the evening or the weekend, it's really not any different than that. That's essentially what the experience is. So it's all about documentation. And I don't know if some schools are recording the sessions with the students. That's another option on some platforms.
Certainly you'd want to disclose that. If you're doing telehealth and you're going to be recording it in any way, would be important. And also to make sure that the student understands what could be the limits of the technology that you're using in terms of privacy.
Okay, thank you. There were quite a few questions about what to tell the cleaning staff, housekeeping, food services. Do you want to weigh in on that?
Only that the recommendations for disinfection are to use standard disinfection techniques that you would in everyday life and everyday healthcare. You don't need to do anything special for this virus. It's very susceptible to all the routine disinfectants that are EPA approved in healthcare settings, so it's very different than norovirus, for example, which does need special work and in bleach. And this is a lipid-enveloped virus, so it's very susceptible to soap and water, and anything that will emulsify the virus should work fine. So that in terms of, I don't know if the question about housekeeping was specific to the health service or resident. Looks like some are in terms of dorms and other in classroom spaces. I would say just the routine procedures. The most important thing is just to have a plan for ramping up the cleaning of surfaces. I know some places have had a team, some hospitals have a team of whether they're volunteers or staff, but they go spend their entire day going around wiping down doorknobs and elevator buttons.
I think it's going to be hard to tell your custodial staff not to wear masks, but you could at least share with them that masks really are for the patient or the person under observation or under investigation, and not really for those of us who are cleaning the space afterward. That is a situation under which you use gloves and an appropriate covering type gown, but not necessarily a face mask. That being said, face masks make people feel more comfortable. If we're in a world where face masks are unlimited, then I'm not sure that if that's what makes the difference of having someone feel confident to do their job. I don't know that it's such a bad thing.
And CDC has extensive guidance on their website about disinfection and cleaning in both home settings and healthcare settings. So I'd refer you to that for more detail.
Okay, thank you. Okay, so now the big one. Do both of you want to weigh in on projections for commencing normal campus life? Summer, fall? Where do you stand on the issue?
Epidemiologists don't like to make predictions.
Yeah, and there probably are very few Americans who aren't familiar with the term flattening the curve at this point, and so much is going to be determined in the next 2 to 3 weeks, I think, as a nation. And when we see what happens, I think we'll have a better idea of how long the outbreak may continue and how long the pandemic may continue. But for right now, we don't know. So don't get tired of doing things to protect yourself and protect your family and protect your patients. They're important. You can't let off the accelerator on those things.
I think as much as things look different now, they're going to continue to look somewhat different in the summer. I think most of us in the academic world are thinking that by fall, we may have some return to normality, but that really depends, of course, on cases. I know a lot of people are optimistic about what's happening in China and South Korea with their decreasing cases, but the concern is if some of those methods are relaxed, some of the social distancing measures are relaxed, will they start to see another upsurge in cases beginning? And we simply don't know that yet. And so that would be really a concern for sort of a second wave of a pandemic. Is that going to happen in the US? Who knows?
Yeah. Do you all want to address the issue of mental health for our frontline workers? Just maybe briefly.
Robin, could you repeat the last part of the
I'm sorry.
question? Yeah.
Do you want to maybe just touch briefly on the mental health of our frontline workers, our student health center and our student affairs folks?
Well, it's a huge issue, and sometimes we look back on times like this. We look back at a norovirus outbreak on our campus. We look back at H1N1, and they were extraordinarily difficult times. But it was a time when we came together as a healthcare team and we did good work, and we made a difference. And so hopefully we'll find as a profession that maybe this is our finest hour and not our most dire hour. That being said, the last two people to ask about the best way to get through this are two people who are retired, and so what I will say is that we're going to have a mental health session. I believe that our session exclusively on mental health will be 2 days from now. Is that correct, Robin? Current plan?
Yes, I think April 3rd is what we're planning at this point.
And I don't mean to dodge this. It's neither Craig and I are mental health professionals, but we certainly recognize how important this is, and how complex it is to try to maintain in the face of really difficult odds, particularly if people around you are becoming ill and you're continuing to move onward.
Well said.
All right, well, I think that might be a good place to end today. I know that there may still be some questions that we didn't get to. We are taking all of those questions that you submitted, and we're trying to incorporate them into this frequently asked questions document that the task force is working on, that hopefully will be uploaded to the ACHA COVID webpage next week. The ACHA Connect is always there if you want to ask your colleagues a specific question. We'll continue to provide support and education as much as possible. And as was mentioned before, next week's Q&A discussion will be on the topic of telehealth. So keep your eyes open for that announcement. And lastly, a big thanks to our guest speakers today. And of course, a heartfelt thanks to all of you out there on the front lines. And I hope you all have a great weekend. Try and get some rest.
Thank you, Robin. Thank you,
you.
everyone, for attending.
Thank you.